This is the second session that describes the mechanics of breathing. The learning objectives are to review the mechanics of breathing, explain factors affecting breathing, describe the respiratory pressures, enumerate the causes of alveolar patency, describe the clinical application of today's lecture. Remember that the respiratory cycle is composed of short inspiration, longer expiration, expiratory pause where the glottis is closed. The respiratory cycle has a rate. The rate of the respiratory cycle is about 12 to 16 cycles per minute. Remember that inspiration is an active process. There is contraction of the diaphragm and the external intercostal muscles, increasing the transverse, the anteroposterior, and vertical diameters of the chest. The increase in the volume of the chest is accompanied by a decrease in its pressure. So the air will move from the high atmospheric pressure to the low pressure inside the chest, and this is inspiration. Expiration, on the other hand, is a passive process where there is relaxation of the already contracted muscle. There is relaxation of the diaphragm and the external intercostal muscles, accompanied by the elastic recoil of the lung and the chest wall. Thus, there is decrease in the transverse, anteroposterior, and vertical diameters of the chest. The decrease in the volume of the chest is accompanied by increase in its pressure. So air will move from the high pressure inside the chest to outside, which is expiration. Now, what are the factors affecting breathing? The factors affecting breathing include the respiratory pressure, physical factors such as the alveolar surface tension, the intra-alveolar dependence, the lung compliance, and the airway resistance. In this session, we will describe the respiratory pressures, the physical factors in the form of alveolar surface tension and the intra-alveolar dependence, while the lung compliance and the air resistance will be discussed later. The respiratory pressures that affect breathing are the intra-alveolar pressure, the intrapleural pressure, and the transpulmonary pressure. Before talking about the respiratory pressure, we should keep in mind that the atmospheric pressure is the pressure exerted by the air surrounding the body, which is 760 mm mercury at the sea level. This atmospheric pressure is taken as a reference when we are discussing the respiratory pressure. If there is no difference between the respiratory pressure and the atmospheric pressure, the respiratory pressure is expressed as zero pressure. If the value of the respiratory pressure is less than the atmospheric pressure, the respiratory pressure is expressed as negative pressure. When the value of the respiratory pressure is more than the atmospheric pressure, the respiratory pressure is expressed as positive pressure. So, negative respiratory pressure means it has a less value than the atmospheric pressure, while positive respiratory pressure means that it's more than the atmospheric pressure. Starting with the intra-alveolar pressure. The intra-alveolar pressure is the pressure present inside the alveoli during the respiratory cycle. The pressure developed inside the alveoli is called the intrapulmonary pressure. So the intra-alveolar pressure is the intrapulmonary pressure. What happens to the intra-alveolar pressure during the respiratory cycle, during inspiration and expiration? At the start of the inspiration, there is no difference between the intra-alveolar pressure and the atmospheric pressure, so the intra-alveolar pressure is 0 mm mercury. It becomes slightly negative in relation to the atmospheric pressure. It's negative 1 mm mercury in early inspiration. This will cause air inflow to the lung, and by the end of inspiration, the intra-alveolar pressure will become atmospheric pressure 0 mm mercury again. While during expiration, it becomes slightly positive in relation to the atmospheric pressure. It is positive 1 mm mercury during expiration. This will allow the air to outflow from the lung, and by the end of expiration, the intra-alveolar pressure will become atmospheric pressure, which is 0 mm mercury again. What happens to the intra-alveolar pressure during Valsalva maneuver? Remember, Valsalva maneuver is a forced expiration with a closed glottis. In Valsalva maneuver, the intra-alveolar pressure can reach up to positive 100 mm mercury. Also, it's important to know what happens to the intra-alveolar pressure during Moeller's maneuver. Moeller maneuver is a forced inspiration with closed glottis. In molar maneuver, the intra-alveolar pressure can be reduced to negative 80 mm mercury. Now let's reflect on the mechanics of breathing. Remember that during inspiration there is contraction of the diaphragm and the external intercostal muscles, thus increase in the transverse, anteroposterior and vertical diameter of the thoracic cavity. When the thoracic cavity volume increase, the lungs are stretched, the intrapulmonary volume increase, accompanied by decrease in the intrapulmonary pressure till negative 1 mm mercury. This allows the air to flow into the lung according to the pressure gradient until the intrapulmonary pressure is 0, which is equal to the atmospheric pressure. While during expiration, there is relaxation of the already contracted muscle, relaxation of the diaphragm and the external intercostal muscles accompanied by the elastic recoil of the lung and the chest wall. Thus, there is decrease in the transverse, anteroposterior and vertical diameter of the thoracic cavity, so the thoracic cavity volume will decrease, accompanied by increase in the intrapulmonary pressure up to positive 1 mm mercury. The air will flow out of the lung down its concentration gradient until the intrapulmonary pressure is 0, which is atmospheric pressure. So remember, the respiratory cycle starts by the end of expiration, where the atmospheric pressure is equal to the intra-alveolar pressure and there is no air movement. During inspiration, the increased thoracic volume results in increased alveolar volume and decreased intra-alveolar pressure. The atmospheric pressure is greater than the intra-alveolar pressure and air moves into the lung. When air moves into the lung, the intra-alveolar pressure equals to the atmospheric pressure again at the end of inspiration. During expiration, the decreased thoracic volume results in decreased alveolar volume and increased in the intra-alveolar pressure. The intra-alveolar pressure is greater than the atmospheric pressure and the air moves out of the lung. Now we'll discuss the second pressure in the respiratory pressure, which is the intrapleural pressure. The intrapleural pressure is the pressure in the potential space inside the pleural sac during the respiratory cycle. The intrapleural pressure is the intrathoracic pressure. Remember that the intrapleural pressure is always a negative pressure. It's always subatmospheric pressure during normal respiration. At the start of inspiration, it's negative 3 mm mercury. At the end of the inspiration, it's between negative 6 to negative 7 mm mercury. And then by the end of expiration, it returns back to negative 3 mm mercury. During forced inspiration, it may reach up to negative 12 mm mercury. And during Moller's maneuver, it may come up to negative 30 mm mercury. While during Valsalva maneuver, it becomes positive 40 mm mercury. Now, this is the time to ask, why is the intrapleural pressure always negative? The answer to the important question of why the intrapleural pressure is always negative is that there is always two opposing forces, a continuous tendency of the lung to recoil and a continuous tendency of the chest wall to expand. And why is this? It's important to know that at the end of a normal expiration, the volume of both the lung and the chest wall together is 2.5 liters. But if we take the lung alone, away from the chest wall, put it in a relaxed state, not compressed or stretched, the volume of the lung is 1 liter. And when we take the chest wall not attached to the lung and not compressed or stretched, the volume of the chest wall in a relaxed state is 5 liters. Putting them together at the end of a normal expiration, the volume of both the lung and the chest wall is 2.5 liters, 2.5 liters. So there is always tendency of the lung to recoil back to its original volume, which is 1 liter, due to the presence of the elastic fiber of the lung and the surface tension of the fluid lining the alveoli. Also, it's important to know that the stretch of the elastic fiber of the lung forms 1/3 of the recoil tendency of the lung, while the surface tension of the fluid lining the alveoli forms 2/3 of the recoil tendency of the lung. and at the same time there is always a tendency for the chest wall to expand back to its original relaxing volume, which is 5 liters. These two opposing forces create a negative pressure in between them known as the intrapleural or the intrathoracic pressure. Now, can the intrapleural pressure be positive? The answer is yes. We said earlier that the intrapleural pressure during Valsalva maneuver, it's positive. It reached up to positive 40 millimeter mercury. Another situation where the intrapleural pressure is positive is the tension pneumothorax, and this is due to the presence of a valve-like action allowing the air to pass inside the pleural sac and not out of it. So the intrapleural pressure will be positive. Now, what is the importance of the intrapleural pressure? The intrapleural pressure is important as it helps lung expansion, venous and lymph return to the heart, and the intrapleural pressure is a measure for the lung elasticity. The third pressure of the respiratory pressures is the transpulmonary pressure. The transpulmonary pressure is the pressure difference across the wall of the lung. It's represented by the intrapulmonary pressure minus the intrapleural pressure. The transpulmonary pressure is the pressure that keeps the lung against the chest wall. So always remember the following important points. Changes in the intrapulmonary pressure occur as a result of changes in the lung volume. Pressure of the gas is inversely proportional to its volume. The increase in the lung volume is accompanied by decrease in the intrapulmonary pressure below the atmospheric pressure, so the air goes in, while the decrease in the lung volume is accompanied by increase in the intrapulmonary pressure above the atmospheric pressure, so the air goes out. The intrapleural pressure is always negative. The volume of air that goes in and out during quiet breathing is 0.5 liter, which is known as tidal volume, and we'll discuss it later. Now we will discuss the physical factors that affect breathing. The first factor is the alveolar surface tension. Remember that the alveoli are lined with a thin film of fluid. The attractive force between the adjacent molecules of liquid are stronger than the attractive force between the molecule of liquid and molecule of gas in the alveoli, which creates a surface tension. According to the law of Laplace, the pressure tending to collapse an alveolus is directly proportional to the surface tension generated by the molecule of liquid lining the alveolus and inversely proportional to the alveolar radius. Because of the inverse relationship with the radius, the large alveolus, the one with a large radius, will have a low collapsing pressure and therefore will require only minimal pressure to keep it open. On the other hand, a small alveolus, the one with a small radius, will have a high collapsing pressure and require more pressure to keep it open. Thus, small alveoli are not ideal because of their tendency to collapse. Yet, from the standpoint of gas exchange, alveoli need to be as small as possible to increase their total surface area. This fundamental conflict is solved by the surfactant. What is the importance of surfactant? Remember that surfactant is formed by type II alveolar cells. When surfactant is present, surface tension and collapsing pressure are reduced, and the small alveoli are kept open. The presence of surfactant increases the lung compliance, which reduces the work of expansion of the lung during inspiration. So, surfactant is important as it decreases the surface tension, it promotes lung expansion during inspiration, it prevents alveolar collapse and loss of lung volume at the end of expiration, and it facilitates recruitment of collapsed alveoli. The second physical factor that affects breathing is the intra-alveolar dependence. Remember that alveoli are made of elastin and collagen fibers, and they are connected to one another. So, if one alveolus starts to collapse, the other are going to pull on it and hold it back in its place. The only place where we don't have these interconnection is where the alveoli are close to the pleural surface. Now we can ask, what keeps the alveoli patent and stable? The answer is the presence of negative intrapleural pressure, the presence of lung surfactant, and the presence of intra-alveolar dependence. What could be the clinical application of today's lecture? The first clinical application of today's session is the neonatal respiratory distress syndrome, where there is absence of surfactant. It's important to know that in the developing fetus, surfactant synthesis begins as early as gestational week 24 and is almost always present by week 35. The more prematurely the infant is born, the less it is likely that the surfactant will be present. Infants born before gestational week 24 will never have surfactant, and infants born between weeks 24 and 35 will have uncertain surfactant status. As a result of lack of the surfactants, the small alveoli will have increased surface tension and increased pressure and will collapse. This is a state of atelectasis. The collapsed alveoli are not ventilated and therefore cannot participate in gas exchange. Also, without the surfactant, the lung compliance will be decreased, and the work of inflating the lung during breathing will be increased. The second clinical application of today's session is the pneumothorax. It's the condition when a sharp object punctures the intrapleural space and air is introduced into the space. In the pneumothorax, there is no negative intrapleural pressure, and there are two important consequences of the pneumothorax. First, without the negative intrapleural pressure to hold the lung open, the lungs collapse. Second, without the negative intrapleural pressure to keep the chest wall from expanding, the chest wall springs out. By this, we finished today's session. Hope that you enjoyed it. Thank you.